Cassidy.
Hey, thank you all. Great panel. I'll focus on Drs. Cooper and Maddox. I could have done others, but I'm just going to choose you all for interest of time. It seems like we almost have a kind of cross-cutting problem of consolidation and solutions of consolidation. I say that because when we see that hospitals or insurance companies purchase physician practices, in the case of hospitals, it drives up cost. In the case of insurance companies, it may drive down costs, but there's no evidence. Some of that cost appears to be, in fact, much of it appears to be retained by the insurance company. Private equity, which is another subject of this, actually provides competition to that. The private equity group actually has the incentive for their physicians to do their care in the lowest cost setting of care, as opposed to in a hospital where you could argue, and sometimes allegedly it's being used to support bricks and mortar. Dr. Maddox, is that kind of a fair kind of framing of at least one way to frame this discussion?
Yeah, I think, Senator, you've brought a very important nuance to the discussion, which is to say that as long as people are competing with the right incentives, maybe it's a good thing to bring innovation and fresh eyes and new money into healthcare. But in order for that to ultimately benefit patients, we have to make sure that they're competing in the right ground to do that. So if that means investing in primary care, creating wraparound services, keeping people out of the hospital, ultimately making them better, and that's a way that private equity can disrupt some of this consolidation, then there is potential for benefit. We just have to create the policy circumstances such that that's where they focus and not on the, sort of profit maximization by driving up prices in ophthalmology or, turn and burn hospice. It's a great nuance.
Dr. Cooper, would you add to that?
Yeah, so I think the first thing I'd say is not all mergers are bad. We have to look deal by deal. I think when it comes to private equity, there is some evidence of some of the acquisitions doing a decent job. So I think fertility services are an area where we've actually seen them do really well. You can juxtapose that with, say, physician staffing companies in the emergency room space where they were, I think, not working in the public interest. So I think it's creating this sort of environment where when they enter, it's basically easier for them to make money doing good for patients than it is for sort of gaming the system.
I think that's actually well put. I saw in one of the articles I read that they decreased their staffing ratio, but their outcomes actually improved. And so it tells me that there are efficiencies that you can bring. I met with some physician groups who frankly are owned by private equity, and they started talking about the billing cycle. As a practicing physician, I never had a clue what a billing cycle was. But I suspect that Mr. Martin's people now do.
Yes, all too well.
Well, it brings that sophistication in that allows somebody to otherwise maintain a modicum of independence when otherwise they would not. Many physicians lack the sophistication of that. Going to the quality, I think Dr. Cooper and Dr. Maddox, you raised the point that quality maybe in one setting is not as good, in another setting improves with the intervention of private equity. I like the way you put it. You make more money if you take better care of patients. That's a good thing. And of course, if you couple that with value-based arrangements. So, Dr. Maddox, real quickly, what would you recommend as the way to structure it so that if there's a disruptor that comes into the market breaking up status quo, that the disruptor actually is incentivized to do the right thing and by, if you will, bringing in competition, incentivizes status quo to do better?
That's a great question. I think the idea is that if people compete on total cost of care models where they win by keeping people out of the hospital and healthy over a prolonged period of time, not just, for next week, but when we're thinking about really investing in long-term health, we should want people to come in and disrupt that. We've created a system that pays for people being sick and not for people being well. So if you put money in a space where if you improve equity and keep people healthy and out of the hospital and, beat chronic disease, you win, that's great.
So by that, you're actually agnostic as to what the entity is. Rather, you're kind of doubling down on the fact that we have to have economic incentives aligned.
Exactly. Economic incentives and the data to be able to monitor them. Right now, the private sector wins on data, and so they find the loopholes much faster than the regulators can close them. So we need to proactively design a system such that people are going toward very concrete, very clear, very positive for patients.
Got it. With that, I yield. Thank you.